It's now my pleasure to introduce our third panelist, Dr. Richards. Dr. Richards applies his training in internal medicine, epidemiology, and health services research to improve health equity and human rights through clinical and population-based participatory research. In addition to his general internal medicine practice and teaching responsibilities and caring for homeless individuals on the streets of Santa Monica, Dr. Richards conducts forensic evaluation of torture survivors and individuals seeking asylum in the United States. He's helped pioneer methods to document population-level exposures to human rights violations and to quantify their impact on mortality and health outcomes, and to validate quantitative findings through linkage with clinical forensic examinations documenting the physical and emotional consequences of torture and other forms of severe trauma. Dr. Richards holds an MD and an MPH from Johns Hopkins University School of Medicine and Bloomberg School of Public Health, and a PhD in health services research from the Fielding School of Public Health. He's also on the board of Physicians for Human Rights. Let's welcome Dr. Richards.
Well, thanks to the School of Public Health and the Promise Institute for hosting this lovely event and for allowing me to talk to you about excellent public health tools to advocate for migrant rights and health. So I like the tie-in to narrative. I too am a fan of stories, and most human beings, including most policymakers when they're slightly human, understand the world and anchor their decisions based on individual stories. So I'm going to share 3 stories that are based on my application of clinical skills to conduct these forensic evaluations of asylum seekers who have experienced severe forms of trauma and abuse. So for each case, we'll explore how to apply public health tools to advocate for migrant health and rights. So to do this, we're going to describe the public health challenges they face, define our objectives and policy goals, decide how we're going to get there, select from our quiver of public health tools, and decide whom we need to partner with, because it's a long way to go, and to get there, we have to work together. Actually, foundational to our advocacy is Article 14 of the Universal Declaration of Human Rights and the UN Convention on Protocol on the Status of Refugees. And these recognize the right of persons to seek asylum from persecution. They state, quote, "Refugees should not be penalized or arbitrarily detained. No one shall expel or return," that's this idea of refouler in French, "a refugee to a territory where he or she fears threats to life or freedom." How does this apply to the US? Well, we ratified the Refugee Convention in 1968, and we enshrined all of these principles into US law with the Refugee Act of 1980. So asylum seekers, by definition, have articulated a credible fear for their safety and health in their home country. Removing them from the US can be tantamount to sending them into harm's way. For those truly at risk, the most important public health intervention is to assist them in their case for asylum. A deeply disturbing article that I recommend to you in that issue of the New Yorker documents what happens when the asylum process gets it wrong and deportation becomes a death sentence. Journalists from the Columbia School of Journalism identified over 60 cases of deportees who had paid the ultimate price for being deported. Often, like Laura, who's the woman in the photo there, they attempt to articulate their credible fear, but they go unheard and unheeded, and they are deported and killed. So in the cases that follow, we can explore how our advocacy efforts might assist other migrants to avoid a similar fate. So we begin in detention, where we meet Oni, who is an indigenous woman who organized against an oil pipeline passing through her people's traditional lands. Several of her fellow activists were killed. She was beaten and tortured, and her life was threatened. She found her way to Mexico, was apprehended soon after crossing into the US. She was placed in a small cell with dozens of other migrants in a single toilet. Soon after that, she was transferred to the Adelanto detention facility, which is right here in San Bernardino. And when we met her, she was depressed and contemplating suicide. Anyone been to Adelanto? Raise your hand. It looks and feels like a prison, perhaps because it was constructed and operated for a while as a prison. It's now operated by the Geo Group, which is a for-profit corporation. So what are the obstacles she faces to her health and safety? Well, the first is the looming threat of deportation. So to advocate for a fair resolution to her personal case for asylum, our immediate target of our advocacy is the judge, right, who will decide on her case. So we partner with a clinician like myself from the National Asylum Network of Physicians for Human Rights and conduct a forensic evaluation that'll document the physical and emotional scars that result from her torture and abuse. Asylum cases with forensic evaluations are associated with grant rates that are nearly twice as high as cases that don't have such evidence. So while there are cases in process, and they're increasingly delayed due to the large volume of cases coming through the system, we can take on a second health challenge and advocate for improved conditions of her detention, starting with access to quality mental health services. So lawyers from our colleagues at Disability Rights California recently partnered with clinicians here at UCLA to document conditions at Adelanto for detainees with disabilities with a particular focus on mental health. So among their findings were poor access to mental health services, inappropriate reliance on solitary confinement, and underreporting of suicide attempts, which she seems to be at risk for. So the report targets the Geo Group and government agencies at multiple levels, county, state, and federal, that oversee and play various roles in the Adelanto operations. So although it won't affect her directly, we can also advocate, right, for the conditions in many of the smaller facilities that we were talking about before that are run by CBP, or the Customs and Border Patrol. So the huge influx of migrants is totally overwhelming these facilities and resulting, again, in the deaths of some highly unfortunate folks. So public health professionals in LA are drawing on their experience in humanitarian settings, right, to partner with the US congressman who went to undergrad here, go Bruins, and to forge legislation that create minimum standards for individuals in CBP custody. And the bill, people are familiar with the SPHERE guidelines, right? These are minimum standards for things like water and sanitation, food, nutrition, and even just the physical space, right, that people need in order to live healthy lives, and thrive. And this is developed for complex emergencies. Here we are applying that, in our own country. Who would have thought? Rose is 22. She was pressured to date a gang member who sexually abused her. She was promised work in a nail salon, but instead she worked without pay and was forced to have sex with several clients. So we find her living in a shelter, having difficulty getting out of bed and finding work. She's applying for a T visa, which is a mechanism for victims of human trafficking to be able to live here in the United States. So how are we going to respond? Well, again, one of the first things we can do is apply our clinical skills to conduct a forensic evaluation that assists with her T visa, application. But then we can also use our epidemiologic skills, right, to understand who migrants like her are, what they've been through, and the health challenges that they face. So the figure on the left displays the prevalence of exposure to threats and violence found in a survey of individuals who were part of the recent migrant caravan. And this is in Texas. Over 80% said they immigrated due to violence. Half reported a history of death threats, and a third reported murder of a family member. The figure on the right highlights the striking commonality of mental health diagnoses among migrants, with 1 in 3 meeting criteria for PTSD and 1 in 4 meeting criteria for depression. In the Q&A, we can discuss additional opportunities to advocate for Rose. So as part of a team with Physicians for Human Rights, I visited Tijuana in February, met migrants like Maida, who's 35. Her husband was killed when he was in the wrong place at the wrong time, witnessed a murder perpetrated by the police and a gang. They threatened her, fired shots at her home, and during her migration north, she saw members of the same gang, like along the route. She's heard that some are there in Tijuana, and she's too afraid, right, to leave the shelter where she's staying, actually with a daughter. So the stay in Mexico policy was announced like the week of our trip, so we took advantage of that. issued a press release and highlighted on social media how staying in Tijuana threatens the mental health and safety of migrants like Maida, and called for an end to the harmful, U.S. policies that keep her there for, way too long. PHR is finalizing reports summarizing results, and giving us chimes to counter, this narrative of that immigrants are violent gang members and drug addicts, who are just making up, these stories about themselves. So human rights violations are shifting from we are protected, state-sponsored violence to non-state actors. The refugee regime was established to create safe haven from state-sponsored violence and is struggling to determine how to handle violence that's perpetrated by paramilitaries, corporations, gangs, and intimate partners. Migration takes a toll on the mental health of everyone, from survivors of trauma to the judges and others of us who hear their stories. Legal residency in the United States is a key determinant of health for people fleeing violence and persecution. And often the most important health intervention is to contribute evidence to corroborate claims of abuse. Our advocacy often targets the government at all levels and all branches, but we shouldn't forget the role of corporations like the Jello Group, or the Geo Group, and companies that ONI was protesting often pay for the protection that leads to the violations. In the Q&A, we can discuss other advocacy opportunities within our own academic institutions. So the public health tools useful for advocacy are those we use every day. This is, and applies to the three-legged stool of teaching, research, and service. As public health professionals, we benefit from a relatively high level of respect, and folks tend to listen when we speak out. So writing commentaries and op-eds, posting on social media, these are all important areas for our advocacy, and opportunities for partnership are everywhere. I think working with lawyers, that tends to be particularly rewarding in this field. So take homes, migrant rights are human rights. And we've focused today, on a rather stark case of refugees. And as I pointed out in the beginning, their rights are recognized by the US. But in this country, we've had a more difficult time, acknowledging and recognizing the legitimacy of the social and economic rights that create duties on states to progressively realize rights to, things such as shelter, education, food, and health. In other words, human rights provide a powerful tool to advocate for the social determinants of health, which are all the rage, du jour. The next takeaway is that you already have the skills to make a difference, and public health knowledge and action inherently promote immigrant health and rights. My hope would be that our advocacy encourages us to reflect on the question of who we want to be as a country. The coverage of family separation, I think, successfully forced us all to ask collectively whether we wanted to be a country that treated children and families with such disrespect and indignity. Whether we could stand by and witness their rights being trampled. I feel that with that issue, the media was successful and told their stories in a way that moved us, and we somehow were able to move the administration, and its policy. So my hope would be that we can apply the tools of public health and medicine to communicate the stories of other asylum seekers like Oni, Rose, Myra, and Laura from the beginning, and begin to transform this narrative surrounding asylum seekers and other migrants to welcome them as our friends and neighbors, entitled to the same rights as all human beings. Thanks.